Thank you so much, Dr. Frias, for joining us for our interview today. We appreciate having you on.
Yeah, my pleasure. Thanks for having me.
Perfect. And then I'm going to start by asking, there's been a lot of developments in obesity and obesity treatment, particularly with tirzepatide and semaglutide. And recently we had the top line results of SURMOUNT-2 with tirzepatide reported. And I wanted to ask if you can comment on those top line results and what they mean in the context of the other trials, particularly SURMOUNT-1.
Yeah, no, absolutely. So as you mentioned, SURMOUNT-2 is part of the tirzepatide weight loss clinical development program, and it is the study that's dedicated to patients with type 2 diabetes. So you mentioned SURMOUNT-1. SURMOUNT-1 was in people without diabetes who had overweight or obesity. SURMOUNT-2, and that was published last June in the New England Journal. SURMOUNT-2, though, is it's a weight loss study looking at patients with type 2 diabetes with a BMI of at least 27, so 27 and above. And the top line results that have been released by Lilly were quite positive, actually. At the end of the study, a weight reduction on average of around 16%. Looking at the 10 and the 15 milligram dose, it was slightly lower with the 10 milligram dose, but clearly far superior to placebo, with a very large proportion of patients achieving greater than or equal to 5%. And I think it was somewhere around 50 or slightly over 50% of the patients achieving greater than or equal to 15% weight reduction. It's a very clinically meaningful weight reduction. So comparing and contrasting that to SURMOUNT-1, anytime that you have a weight loss study in a population with type 2 diabetes, you're going to see less weight reduction than you do in people without diabetes for a number of reasons that aren't totally fully understood. And that's what we're seeing here. From SURMOUNT-1, the mean weight loss with the highest dose of the 15 milligram dose was somewhere around 21, 22%. And again, what we saw in SURMOUNT-2 was about 15, 16% with the 15 milligram dose. And that is to be expected. That's, if we look at sort of the analog, if you will, with semaglutide, 2.4 milligrams, and compare step 2 to step 1, step 2 being the type 2 diabetes study, you saw less weight reduction in patients with type 2 diabetes than you did in patients who did not have diabetes. And then going back to SURMOUNT-2, what's been reported at this point is that the glucose control, because these were patients with type 2 diabetes, was comparable to that was seen in the SURPASS studies. So the SURPASS studies or program where was the type 2 diabetes program, where we saw reductions in A1C of 2+% from a baseline A1C of about 8%, with almost 90+% of patients achieving an A1C of less than 7%. And in many of these studies, over half of the patients achieving normoglycemia or an A1C of less than 5.7%. So bottom line with the SURMOUNT-2, I think from what's been released at this point, very positive data for that study in a type 2 diabetes population, and specifically in a weight loss study in this population.
Thank you. And those were some great points. And sort of like looking forward to maybe later this year when potentially we might have tirzepatide approved, and we're going to be in a really good situation of having two high-impact drugs for obesity treatment approved relatively recently with the approval of semaglutide as well. I know a lot of it has been made with comparing them in a direct head-to-head trial, and I know you can talk more a bit about the SURMOUNT-5 one, but in practice, are clinicians going to think more about, like, do I choose one versus the other? Is this going to be something that is based on the patient and sort of like taking account of the different factors, so like moving forward?
Right, that's a good point. In clinical practice, what we decide to prescribe is based on so many factors. Sometimes it's cost and access. Certainly that's important. The patient, what their insurance will allow them to take is critically important, because these medications aren't inexpensive by any means. But there may be clinical characteristics of the patient that leads the clinician to prescribe one versus the other. I think certainly you mentioned SURMOUNT-5. So SURMOUNT-5 is a head-to-head study that's ongoing, comparing semaglutide 2.4 milligrams, so Wegovy, to tirzepatide 10 and 15 milligrams once weekly. I think having head-to-head data are very important. I mean, we can certainly look across trials, step one, for example, and compare it to SURMOUNT-1, but that's really not the way to do it. We need to do a head-to-head study. So having these data, I think, will be critically important. And then I think clinicians will need to decide. I think there are other important trials that are upcoming, or data will be coming from. The SELECT study, for example, looking at high-dose semaglutide in patients with overweight and obesity with a pre-existing atherosclerotic cardiovascular disease. This is a cardiovascular outcome study in 17,000, I think 500 patients, so a huge study. And then in type 2 diabetes, the SURPASS cardiovascular outcomes trial, or SURPASS CVOT, which is expected to report out in 2024, looking at whether there is or not a cardiovascular benefit with tirzepatide or Mounjaro in patients with type 2 diabetes. And then there's an ongoing study, so-called MMO, morbidity and mortality and obesity study, looking at very, very sort of similar to SELECT, looking at cardiovascular outcomes, et cetera, with tirzepatide in patients with obesity without type 2 diabetes. So I think that plays an important role as well in deciding which therapy. And I think the head-to-head, seeing which of these medications will, on average, result in the greatest amount of weight reduction. Safety and tolerability is always very important as well. So it'd be nice to see head-to-head safety, tolerability, particularly gastrointestinal tolerability. So I think we'll await the results of that study. And in the meantime, I think clinicians make choices based on a number of different reasons and the existing database as well.
Thank you. And then it brought to mind another question, which is obviously there's been a lot of excitement in the field of obesity treatment because of these new developments. I would say for the first time, maybe in decades, of having basically a part that obesity treatments were very underused, and now we sort of have maybe the opposite problem. And I wanted to ask you about maybe if clinicians should not think of these as a magic bullet and what they can do to educate patients better. I know there's been a lot of confusion about using these drugs for the short term and not as for long-term obesity treatment and weight maintenance. So I just wanted to ask about that.
Yeah, so a lot of questions there, and I would say, one important factor with any of these medications is that they need to be used in conjunction with dietary counseling, with counseling about physical activity as well. I think it's very important for patients to be counseled on the importance of resistance training also, so they don't lose, or they lose as little muscle mass as possible. What we want here is loss of fat mass, and particularly visceral fat mass. So it goes in conjunction with lifestyle. And these are not really short-term treatments. Certainly they can cause weight loss relatively quickly, but we know from clinical trials and after clinical trials end, following patients that are now off of medications, has been well characterized, the patients will regain, in general, the body weight that's been lost. So these are sort of lifelong therapies, as you would do with antihypertensives, medicines for dyslipidemia, for example. What I think will be very interesting, and we need more data on this, is, are there perhaps lower maintenance doses once a patient loses their body weight, sort of reaches that plateau in weight loss, and we get to a good target? Can we potentially have lower doses as sort of maintenance doses, if you will? And that's something that will be important to explore in the future. But in general, I think we need to be responsible with our prescribing. Certainly, the selective GLP-1 receptor agonists that are indicated for type 2 diabetes. I think we should be using them in type 2 diabetes. And then the weight loss medications in the appropriate patients who are either overweight with comorbidities. So, the label would say BMI over 27 with weight-related comorbidities, or obese with BMI over 30. But again, lifelong and in conjunction with appropriate lifestyle counseling as well.
Thank you. And another part of the excitement in obesity treatment has to do with several other key emerging therapeutics that are currently in clinical trials. And if you can comment maybe on some select ones and what to look for in the near future.
Yeah, absolutely. So, we're coming upon, we're in kind of mid-June right now, and we're coming upon the American Diabetes Association meetings, and there's actually going to be quite a bit of data on new agents or existing agents at higher doses. So, for example, oral semaglutide, trade name Rybelsus, has been studied in patients with diabetes at higher doses. So currently the highest dose is 14 milligrams once daily. In a study called Pioneer Plus, it was studied at doses of 25 and 50 milligrams once daily. And in a study called Oasis 1, which completed, it was studied at 50 milligrams once daily in patients with overweight and obesity without type 2 diabetes. And very nice results in both of those. In Pioneer Plus, again, this was a diabetes study, not a weight loss study. And that's an important distinction also, because in weight loss studies, patients see dietitians, get a lot of counseling on lifestyle, and generally are given 500 calorie deficit diets, et cetera. Whereas in the diabetes trials, where the primary endpoint is A1C, oftentimes they will just get sort of standard of care lifestyle counseling by the clinician or a nurse. But in Pioneer Plus, the data that's been reported is A1Cs, slightly over 2% with respect to the reduction, dose dependence, a greater reduction with the 50 milligram dose, and I believe the body weight somewhere around 15% average reduction in body weight, and again, dose dependence, a greater reduction with the 25, even greater with the 50 milligram dose compared to the 14 milligram dose. And then in people without diabetes, even greater reductions in body weight. That was a weight loss study. And again, this is without diabetes, where you would expect to see greater weight loss. So very good weight and glycemic control with the higher doses of oral semaglutide. Earlier in development, there's a compound, it's actually a combination of two drugs, which is semaglutide, 2.4 milligrams, and a long-acting once-weekly amylin receptor analog, which is cagrilintide. So this in combination, 2.4 milligrams and 2.4 milligrams, resulted in significantly greater A1C reduction compared to cagrilintide alone, and numerically better A1C reduction compared to semaglutide alone. So the difference was, I believe, if I remember correctly, 2.2% with CagriSema, 1.8 or so percent with semaglutide. But in the weight loss piece, there was about a 16% weight reduction with CagriSema, so the combination of cagrilintide with semaglutide, with 2.4 milligrams of semaglutide, a 5% weight reduction, and with cagrilintide alone, an 8% reduction in body weight. And this was at 32 weeks, a very robust weight reduction when you combine these two agents, the amylin analog with the GLP-1 receptor agonist. That will be presented at ADA. That has also gone into phase 3 trials right now for obesity in both patients without type 2 diabetes and with type 2 diabetes. And then one other I'll mention, there are many others. Well, I'll mention two more briefly. One are the non-peptide oral GLP-1 receptor agonists. So specifically, Lilly has a once daily, which is called orforglipron, that completed phase 2 both in obesity and type 2 diabetes. That will be presented at ADA. Very nice data at 26 weeks in type 2 diabetes. And so we'll look out for that. And the nice thing about the small peptides, and Pfizer has one as well, danuglipron, is that it can be taken irrespective of meals, so with or without food. Orforglipron is once daily, danuglipron is twice daily, but Pfizer does have a once daily oral non-peptide GLP-1 receptor agonist as well. And then lastly, and this will be also presented at ADA, a phase 2 obesity study and a phase 2 diabetes study, is Lilly's retatrutide. And what this is, it's a triagonist, so a triple agonist of the GIP, GLP-1, and glucagon receptor. So as with tirzepatide, this is a so-called unimolecular multi-agonist. So it's one molecule. It's based on the peptide sequence of GIP. It's 39 amino acids in length. And it's an agonist of these three receptors, GIP, GLP-1, and glucagon. And again, very strong initial data that was reported both for weight reduction, in particular, I would say weight reduction in patients with overweight or obesity without diabetes, and also in a type 2 diabetes trial, robust reductions in glucose and in body weight. And that's also moving forward in an obesity program, assessing patients without diabetes and with type 2 diabetes. So there's a lot that will be going on at the American Diabetes Association. I would expect a lot of very good presentations and papers also to follow those, within the month. This meeting's at the end of June. So yeah, a lot of exciting things when it comes to both type 2 diabetes, weight reduction, and improvements really beyond glycemic control, including the importance of liver health as well, and reducing the impact of NAFL or fatty liver disease.
Thank you, Dr. Frías. A lot of things to keep in mind and follow up for sure. And before we finish, I wanted to ask for your quick takeaways about the emerging obesity treatment and sort of like what clinicians can keep in mind overall.
Yeah, so from an obesity treatment point of view, I think, again, it's very important to have the discussion with the patient. I mean, we have, I think the current estimates are that somewhere north of 40% of adults in the U.S. are obese, so a BMI of over 30 kilograms per meter squared. Many of those patients, up to 10%, have severe obesity, BMIs of over 40. We need to, as clinicians, have the discussion with the patients. This is a disease and should be treated as such and diagnosed. And I think with the advent of these incretin-based therapies that have effects on lowering body weight, improving dysglycemia, improving blood pressure, many of the comorbidities and complications of obesity, we have very safe now medications. We need to know how to use them to enhance their tolerability. But to the extent we can get our patients on them, I think it's important to consider these medications as an option. And in some patients, we also have the option, or at least for them to be evaluated for potential metabolic or bariatric surgery. And sometimes they may need both. So I think we have very safe drugs that are efficacious. We see with these investigational agents that the efficacy seems to be getting better and better. We need to just make sure we're diagnosing, we're making absolutely sure the patients understand lifestyle changes are important and use these adjunctive therapies.
Thank you, Dr. Frías. It's been a pleasure chatting with you today, and I know our audience got some really important pointers.
Thank you. Appreciate it. Thanks.